Welcome to the NWA ETC Project Echo. I'm Kent Unruh. I'd like to turn it over to our medical director, Dr. Brian Wood, to introduce our guest.
Great. Big thanks to Bob Harrington for doing this talk. Should be very, very interesting. You all should probably know Bob. Bob's a professor of medicine here and director of the Madison Clinic, and I will turn it over to him.
Good morning, everyone. Thanks for tuning in. My topic this morning is immune reconstitution. This is something I didn't quite get to in my last talk on tuberculosis and HIV. So I've returned to the topic tonight, or this morning rather, and I'll include a broader discussion of the syndrome rather than just tuberculosis and HIV. Well, let's start with a case presentation. This is an actual case, one of my patients from years ago, 47-year-old HIV-infected man who presented with fever, fatigue, and a cough for 6 weeks after starting antiretroviral therapy. On exam, he was febrile, tachycardic, tachypnic, and had a saturation that was reduced at 88%. His chest X-ray and CT showed interstitial thickening, some small pleural effusions, and splenomegaly, which I'll show you here. Obvious interstitial infiltrates bilaterally, some small effusions, which are best seen on the CT scan. So he was admitted to the hospital and underwent an extensive evaluation. He had bronchoscopy, bone marrow aspiration, inguinal lymph node biopsies for continued fever and tachycardia, all of which were unrevealing. He was treated with Bactrim and levofloxacin for pneumocystis and community-acquired pneumonia. CMV antigen was detected in his blood, so he was started on ganciclovir, and then ethambutol and clarithromycin and steroids were added for possible disseminated MAC and immune reconstitution. He improved promptly on prednisone and was discharged from the hospital on a prednisone taper, got much better, returned to work, his chest X-ray normalized, and his T cells went up to 381, so doing quite well for a little while. But then 3 days after completing his steroid taper, he was readmitted with shortness of breath, fever, and diffuse edema. The following day, he developed a consumptive coagulopathy, renal failure, ARDS requiring intubation. He was bronched again, and again it was unrevealing. And despite supportive measures, including antibiotics and high-dose steroids, he died in 3 days. And this is his chest X-ray from his initial admission, on his readmission, and then on the day of his death. He did have an autopsy, and that showed extensive KS in both lungs with atypical lymphocytic infiltration. So this gentleman had cryptic Kaposi sarcoma and then developed an atypical inflammatory response as he was started on antiretroviral therapy that was ultimately fatal. So that is immune reconstitution at its worst, and let's talk about this syndrome. So it is an illness wanting for a definition, and the best we have is that is occurring in an HIV-positive person with a temporal relationship to starting antiretroviral therapy associated with a decline in plasma RNA, HIV RNA, and a rise in CD4 counts. The presentation must have an unusual inflammatory course, and you need to exclude other causes like progression of an underlying OI, a new opportunistic infection that's presenting without an inflammatory response, or drug toxicity, basically anything else that would explain their signs and symptoms. There are two versions, a paradoxical version, which is the most common. This is IRIS occurring when somebody already has a known or previously diagnosed opportunistic infection that's responding to therapy, and then, after starting antiretroviral therapy, deteriorates. The second is an unmasking infection. So in this case, like the first case I presented, the disease is cryptic prior to developing antiretroviral therapy, but then presents with florid inflammatory symptoms after starting HAART. So how frequent is this? Well, its incident rates varies by geographic location and by disease. So for paradoxical IRIS, numbers for tuberculosis are in the high teens, low 20s with quite a broad range. So tuberculosis with a range in around 20%. Cryptococcus is similar, as is PML and Kaposi sarcoma. It's a little harder to get our hands on accurate rates for unmasking IRIS syndromes, but for crypto and TB, they're in the low 1 to 5% range, roughly. There are also risk factors for developing IRIS. So for individuals with advanced HIV that is marked by low CD4 counts and high HIV RNA levels, individuals that have a high pathogen or antigen burden like you'd see in someone with a disseminated infection, individuals that have a strong response to antiretroviral therapy that is marked by a rapid initial decline in plasma HIV RNA levels and a marked increase in CD4 counts. And then maybe most important is a short interval between the treatment of an OI and the initiation of antiretroviral therapy. There are some other factors that show up in some studies but not others. Host genetic factors, whether the patient was ARV naive or not, individuals with low hemoglobin levels, and PI-based antiretroviral therapy in some studies is associated with higher IRIS rates. I'll just walk through this study, which was just published a few months ago from South Africa. It's a nice paper that looked at the development of IRIS syndromes in ARV clinics in South Africa. There were roughly 500 patients who were followed for 6 months after starting antiretroviral therapy. They documented 620 events, meaning inflammatory events or OIs or some significant clinical event that happened in the 6 months after starting antiretroviral therapy. They classified 139 of these 620 as IRIS events. The non-IRIS events included new infections that did not present with a particularly inflammatory presentation, pre-existing disease that relapsed, drug toxicities related to antiretroviral therapy. Those were the reasons for non-IRIS events, but 22% of the events were classified as IRIS. These authors divided the overall IRIS into those happening against typical opportunistic infections. Tuberculosis, whether it was pulmonary or extrapulmonary, led the list, given that the location of these clinics was in South Africa. But cryptococcal disease, KS, and candidal esophagitis were also fairly common. More common than classic OIs were mucocutaneous IRIS. So this is just the development of a folliculitis or recurrent genital herpes, warts, extragenital herpes that kind of flared after initiating antiretroviral therapy. So the overall rate for IRIS in this population of 500 patients was 22%. Now, what about the timing of the disease? Well, most of it is clustered early after starting antiretroviral therapy. So here, the upper curve, there's not really a curve, but the upper hash marks are documenting the non-IRIS events. And then the triangles and circles mark the IRIS events. And you can see that most of them were clustered in the few weeks following antiretroviral therapy. And then they kind of settled out at a much lower level over time. In this study, IRIS was responsible for 24% of all deaths, 28% of ARV changes, so perhaps some of the time physicians thought that the patient was having a drug reaction, and so they decided to change antiretroviral therapy, and it was responsible for 20% of all hospital admissions as well. So how does somebody get IRIS? What is the pathogenesis of this syndrome? It's fairly straightforward. One starts with immunodeficiency that is related to HIV that allows for the development of an opportunistic infection. And then individuals are started on antiretroviral therapy with immune recovery. And that immune recovery can be classified as the repopulation with interferon-producing effector memory CD4 T cells, the repopulation of CD8 T cells, and also the repopulation of macrophage, gamma delta T cells, and natural killer cells. But in addition to all that repopulation, there is a defect in regulatory T cells that just doesn't handle this reactivation very well, so that there is a dysregulated immune response to the OI or the antigens that are present, leading to the enhanced inflammatory syndrome. So clinical symptoms, that we associate with IRIS, new or worsening adenopathy that you might see with tuberculosis, mycobacterial disease, or Kaposi sarcoma, hepatitis flares if someone is chronically infected with Hep B or Hep C, pulmonary infiltrates again with tuberculosis and disseminated fungal infections, of vitritis in individuals who have CMV retinitis, and then multi-organ systems in individuals with disseminated infections, many of which I just mentioned, central nervous system symptoms in people that have PML due to JC virus, and cryptococcal meningitis. There are some recent studies, one by Phil Grant for ACTG 5164, that looked at predictors of the development of IRIS, and individuals with elevated levels of IL-2, 8, and 17, or higher levels of interferon and TNF-alpha can be associated with the development of IRIS. So that's IRIS in general, but maybe we could spend a little time talking about a few particular pathogens that are associated with immune reconstitution syndrome. The first is TB-IRIS, and I'll bring us back to the SAPIT trial. The SAPIT trial was designed to see which strategy of the timing of antiretroviral therapy led to better outcomes in people that had tuberculosis. But a secondary analysis was done to describe the development of IRIS in this study. So just to remind everyone about the SAPIT trial, this started patients who had tuberculosis on antiretroviral therapy within 4 weeks of treating their TB. That was group 1. Starting antiretroviral therapy within 4 weeks of completing the intensive phase, which is usually 8 weeks of therapy. So starting antiretroviral therapy 8 to 12 weeks after starting TB therapy, that's group 2. And then the third group is waiting until you complete your TB therapy, so that's 6 months into your treatment course. That's group 3. There were 642 patients in the SAPIT study, and IRIS developed in 85 of them. Most of that was in group 1. So there were 43 cases in group 1, and if you look at the graph here, you'll see that the timing was earlier, and up to 20% of people in group 1 developed IRIS. If you waited until starting antiretroviral therapy at 8 weeks or at 6 months into treating TB therapy, then you developed IRIS later, obviously, because you were starting antiretroviral therapy later, but also had fewer cases. The symptoms of TB-IRIS that were marked in this study were respiratory symptoms, recurrent pulmonary infiltrates, organomegaly, skin lesions, cervical adenopathy, neurological symptoms. So wherever TB was, that's where your symptoms developed. And since most tuberculosis infections were pulmonary, there was a resurgence of pulmonary symptoms and radiographic signs of TB-IRIS. The median time to the development of IRIS from starting antiretroviral therapy was roughly 2 weeks in the 2 early arms, so 17 days in each, and a little bit later in the sequential ARV arm, where they started ARV therapy 6 months after completing TB therapy. The time to resolution of IRIS was longer in the earlier arms than it was in the sequential arms, and there was more severe IRIS early as well. There were 2 IRIS-associated deaths in the individuals who started antiretroviral therapy early, and none in the integrated and sequential arms. This study, I thought to add into the lecture this morning, this was a recent publication on tuberculosis meningitis. So this was a prospective observational study of 34 HIV-infected patients with TB meningitis, and IRIS occurred in half of them. TB-IRIS was associated with increased rates of individuals being culture positive for TB from the CSF, and those individuals that had higher CSF white cell counts, 50 versus 3, had higher rates of TB-IRIS. They also marked that the combination of elevated CSF TNF levels and low CSF interferon levels was predictive of the development of TB-IRIS. So what do we do when we diagnose somebody with this illness? How do we treat them? Most of the data comes from anecdotal reports or small series. There's been only one study, this one, that was published a couple of years ago, a double-blind randomized placebo-controlled study looking at the intervention of fairly high doses of prednisone, so 100 milligrams of prednisone daily for 2 weeks, followed by roughly 50 milligrams daily for 2 weeks. Assessments were performed at 1, 2, 4, 8, and 3 months into treatment, and the treating physicians could switch from the randomized study to open-label prednisone if they felt their patient was deteriorating or relapsing. So the primary endpoints for this study were total hospital days, outpatient procedures, and the mean number of hospital days. And if you see here in the prednisone group, they had fewer hospital days, fewer outpatient procedures, and mean hospital days of only 1 compared to 3 in those people who were treated with placebo. The symptom score at week 2 or week 4 in the prednisone arm, so the orange bars are improvement, the blue bars are deterioration, so a better symptom resolution at 2 and 4 weeks in the prednisone arm compared to the placebo arm. And chest radiographs similarly improved. Again, orange is improvement, blue is deterioration, so the prednisone arm had better chest x-ray scores at 2 and 4 weeks compared to the placebo arm. So conclusions from this study were that prednisone reduced the need for medical interventions. It had a consistent benefit of symptoms and radiographic appearance, and the benefit existed despite there being the ability to cross over to an open-label study where patients were treated with prednisone if they were worsening. There was no excess steroid toxicity or infection, and the authors made the point that the optimal duration of treatment was perhaps a little short in some individuals. 4 weeks was what the trial study was set up to deliver, and prednisone was extended for some people who continue to have symptoms beyond 4 weeks of therapy. So let's look at a second infection. This is Cryptococcal IRIS, and I want to bring your attention to 2 studies. The first was published 3 years ago now, an open-label randomized controlled trial of individuals with HIV and cryptococcal meningitis who all received high-dose fluconazole, 800 milligrams daily for 10 weeks, and then were put on maintenance fluconazole after that. The intervention was starting antiretroviral therapy, kind of an old-fashioned regimen, but ARVs nonetheless. The early patients were started immediately after the diagnosis and treatment of cryptococcal meningitis, meaning within 3 days of their diagnosis. And the delayed group did not start antiretroviral therapy until they'd had 10 weeks of fluconazole. And the primary outcome was mortality after 2 years. And they enrolled 50 patients in the study. Those in the early group, their 2-year mortality was 87% compared to 37% of those who had a delayed treatment of their HIV. And the Kaplan-Meier curve shows that those who were treated late or delayed had a better survival. This is survival over time compared to the people that were treated early. And you can see that the curves diverged relatively early in the study so that most of those deaths happened soon after starting therapy. The second study I wanted to bring to your attention was just presented at the Conference on Retrovirus Infections earlier this year. This is the COAT study, or Cryptococcal Optimal ART Timing. Its design was early antiretroviral therapy, meaning starting antiretroviral therapy less than 2 weeks into treatment versus waiting until after 4 weeks into treatment. The goal was 250 participants in each arm. And the results, we'll just cut to the results. It was halted after 177 patients were randomized because the 6-month survival in the early treatment group was 55% compared to 70% in those who were delayed treatment. A secondary analysis showed that mortality was worse in people who presented with altered mental status or in individuals who had low CSF white cell counts. And there was a trend towards increased mortality in the groups that had a diagnosed IRIS syndrome. So recommendations from this study were that anti-cryptococcal therapy should always come before antiretroviral therapy. In general, you should wait to start antiretroviral therapy for a month and consider waiting even longer if patients had presented with severe disease that is marked by altered mental status or a non-inflammatory CSF. So the last infection we'll talk about just quickly is that of CMV and CMV precipitated IRIS. So this is the development of anterior chamber or vitreal inflammation in response to CMV retinitis that occurs after initiating antiretroviral therapy. Inflammation in the chamber can lead to macular edema, epiretinal membrane formation, and retinal neovascularization. And it's pretty straightforward to make this diagnosis. On the left is a picture of what CMV retinitis looks like. So these exudates and hemorrhage that are following along blood vessels in the retina, and you can see right through a clear vitreous onto the retina and make out this infection pattern. But in individuals who have vitritis, there's intense inflammation of the vitreous, so you typically can't see the retina at all and can't make out those line marks. So fairly straightforward diagnosis. In this meta-analysis, which I showed earlier of ART-associated IRIS, the rates for CMV were among the highest of all opportunistic infections. So each dot here on this graph represents an individual study, and you can see the blue dots represent CMV, and there are rates of between 20 and up to over 50% in some individuals who have the diagnosis of CMV retinitis and are started on antiretroviral therapy. The risk factors for developing it include the use of intravitreal cidofovir to treat CMV retinitis and starting antiretroviral therapy before completing the induction phase of CMV treatment. Treatment is steroids, and outcome is variable. Unfortunately, some patients are left with significant defects in their vision even after good treatment with anti-inflammatory therapy. So in conclusion, there's many other IRIS syndromes that we could talk about today. In fact, if you can name an OI, for the most part, there's been an IRIS syndrome that's been associated with that. I just presented 3 common ones this morning. And IRIS we can define as an inflammatory disease that occurs in the context of initiating antiretroviral therapy and can be classified as paradoxical or unmasking. The incidence varies greatly by geographic region and by the disease that you're studying. Major risk factors include advanced HIV, a low CD4 count, disseminated infections marked by a high organism or antigen burden, and a short interval between the treatment of the OI and the start of antiretroviral therapy. Management generally includes continuing treatment of the OI and antiretroviral therapy, plus supportive care and the addition of anti-inflammatory therapy that can include nonsteroidal drugs, steroids, or thalidomide based on the severity of the syndrome. Outcomes are generally good with low mortality, the exceptions being cryptococcal meningitis, which can have a poor outcome, and like the first case that I presented today, individuals with visceral KS can have a difficult to control syndrome despite steroid therapy.